I'm very happy, very happy to be here for this opportunity to speak to many oncologists. I am also happy representing the Philippine Society for Fertility Preservation to be partnering with 5 other oncology societies. And I will be discussing a little bit more about the alliance that we can potentially do more in the future. So my topic is on fertility preservation for cancer patients, state of the art in the Philippines. These are my disclosures. And we will be discussing the need for fertility preservation in the treatment of young cancer patients, enumerate the various strategies for fertility preservation in both men and women, including those available locally, and describe the current efforts to promote fertility preservation in the Philippines and how they can be part. My outline is essentially the objectives that I mentioned. So let's start with the need for fertility preservation. Fertility preservation is the process of saving or protecting oocytes, sperm, or reproductive tissue so that one is potentially able to use them for use in the future. This is an exciting new discipline to keep up with the progress in other fields, like what is progressing quite rapidly, cancer therapy. So there is now an increased demand worldwide for fertility preservation services. There are actually many indications for fertility preservation, and for our webinar tonight, we will just focus on those involving cancer therapy. Oncofertility is a word that was coined in 2006 by Dr. Teresa Woodruff of Chicago, and it is the field that bridges oncology and reproductive medicine. It deals with maintaining the reproductive potential of cancer patients while receiving the recommended cancer therapy as needed. The reason why this came about is because of this. Over the past decades, there has been a doubling of cancer survival, especially here expressed in the 10-year cancer survival. So with the increase in cancer survival, there are now more patients who will be able to have a longer life. And we expect that 9 to 10% of these will be in the reproductive age group. And following the 9 to 10% percentage, it will be estimated that there are about 17 to 18,000 patients yearly in the Philippines that may potentially require fertility preservation. If you follow the estimates of Global Can in 2018, the estimate is fairly similar, about 14,000, a little bit over 14,000. So it is a significant number of patients that we must address and give service for. So currently what happens is cancer patients are diagnosed and then they go straight to treatment. And when they survive, they have quality of life issues. And among them is infertility, which has been found to be the single biggest concern among young cancer survivors. Why is this so? I am glad that our first 2 speakers touched a little bit about pathophysiology, so gives me just to focus on the core. In women, the risk of ovarian failure after chemotherapy or radiotherapy follows the toxicity of the agent that was used. The greatest is really pelvic radiation, followed by the various classes of chemotherapy, the biggest of which are the alkylating agents as discussed by Dr. Francia. As for treatment, for cancer treatment, they showed previously the graph of the ovarian reserve decline over time. They say that every time you give cancer chemotherapy for each course, it decreases the ovarian reserve for approximately 7 to 10 years. So that if you apply the chemotherapy at an older age, there will be probably much less follicles left as compared to when it is applied when the patient is younger. Similar facts occur in the male, where there's also risk of damage to the testes after cancer therapy, whether radiotherapy or chemotherapy. Probably the most important thing I need to emphasize is that there is a difference in the resistance to the gonadotoxic effects of chemotherapy and radiotherapy by the Leydig cells, which form the hormones, and the spermatogonial stem cells, which eventually form the male gametes. So the male gametes, as the spermatogonial stem cells, are really much more sensitive, and they will be the earlier failure, they will be victims of cancer therapy as compared to Leydig cells. So it's possible for boys to undergo normal puberty but are infertile. This graph was already shown by Dr. Francia, whereby comparing patients with cancer, overall the decrease is about 40% compared to those who don't have cancer. And most noteworthy really are those patients with breast cancer. Without any fertility preservation, their chance for pregnancy is about 60% or so less. And of course, varying chances for pregnancy along the different types of cancer. I just wanted to briefly talk about this particular study by Lorish, where they show that in breast cancer patients, treatment or delaying treatment before chemotherapy by 1 to 3 months does not seem to decrease the survival rate in breast cancer as compared to delaying it further to the 4th month. So in terms of 5-year breast cancer survival, there seems to be no effect in delaying them for the first 3 months as compared to an extension to the 4th month. I leave this to the oncologist to see if this is an acceptable study, but this is something that we'd like to look further on, just to give us a little bit more time in treating patients for fertility preservation. This was already mentioned by Dr. Francia, the different classes of chemotherapeutic agents. The high risk are your alkylating agents, and those with the lower risk are your methotrexate, your bleomycin, and actinomycin. So because of all this fuss about gonadotoxicity and fertility, the ASCO and the ASRM, that is our organization, that is the American Society for Reproductive Medicine, have both brought out similar updates on fertility preservation over the years. Essentially, healthcare providers should discuss the possibility of infertility as soon as possible before gonadotoxic treatment, and the patient should be referred, for those who express an interest in fertility preservation, to reproductive specialists. If you compare the profiles of cancer in different age groups, it would appear like this. For those who require fertility preservation in the 19 to 35 age group, 50% are breast cancer, 25% are hematological malignancies, another 15% gynecologic, and the sprinkling of others in the remaining. Whereas in young girls, 3 to 18 years old, the bulk are shared by hematologic malignancies and hematologic benign diseases, and the sprinkling of others for the other smaller percentages. So, in summary for that, patients who undergo diagnosis and go straight to therapy, we hope that you could refer for fertility preservation first before you undergo cancer therapy, so that when they do survive, we are able to provide them a chance to have future children. Let's go to the available options of fertility preservation in the Philippines. For post-pubertal fertility preservation studies in males and in females, there are experimental and established strategies. For the males, it's basically established semen or sperm cryopreservation and fertility-sparing procedures like gonadal shielding. And the experimental method is testicular tissue cryopreservation. In the females, post-pubertal, it's a little bit more complicated. You have ovarian tissue cryopreservation, oocyte, mature oocyte cryopreservation, embryo cryopreservation, and fertility-sparing procedures and surgeries, which is normally in the realm of the gynecologic oncologist. And we have experimental procedures, IVM, in vitro maturation, and your GnRH agonist suppression. We'll be going through most of these. However, The general principles that we follow in choosing the strategy: the fertility specialist will work within the time limit set by the oncologist, what we call the FP, or the fertility preservation window. If you have 2 weeks or more, we will be doing embryo freezing if the patient has a partner, or oocyte freezing if she's single. If if the tumor is hormone sensitive, then we'll be adding letrozole to the stimulation. And then there are many options in ovarian stimulation that we can do so that we can shorten the amount of time that we will need for doing our strategy. However, if we have less than 2 weeks, our choice will be ovarian tissue cryopreservation with subsequent transplantation when the patient goes into remission. Another option will be to give GnRH agonist co-administration for ovarian protection before and during chemotherapy. Just to review quickly your embryo and oocyte cryopreservation as fertility preservation strategies, the aim is to store a sufficient number of embryos or eggs for future fertility following the IVF process. So after a 2-week period of controlled ovarian stimulation, the eggs are retrieved, or the oocytes are retrieved by ultrasound-guided needle aspiration. If they are single, they are for oocyte cryopreservation straight to preservation by vitrification. However, if the patient has a partner, they will be fertilized with sperm and they will form embryos, whether up to day 3 or day 5, before they are vitrified for cryopreservation. There are several options that we can do for controlled ovarian stimulation, and this is the part that actually takes time. Standard is to do a conventional start, meaning at the start of the cycle, normally day 2 or day 3, we start with the injections of your gonadotropins. However, we can also do late follicle start or luteal phase start. So now we have random start ovarian stimulation so that we don't need to wait for the coming of the early part of the cycle, which further takes up time, delaying chemotherapy or radiotherapy. So what about with random start? With random start ovarian stimulation, they would yield a comparable number of oocytes, including the developmental potential of oocytes becoming embryos, with reduced time interval from ovarian stimulation to cryopreservation. The only disadvantage with random start is that you use up more doses of gonadotropins, meaning a little bit more expensive. And as I said, in breast cancer patients, which is an example of a hormone-sensitive tumor, when we use gonadotropins with letrozole, it will decrease the level of your estradiol to less than 500 during the entire cycle, compared to in the thousands, level of thousands for those where you don't do letrozole, where you don't include letrozole. And yet, the number of oocytes are comparable. They're the same. In fact, it's a little bit more in those with letrozole. The strategy of mature oocyte cryopreservation for a while was not accepted as an established strategy. But with the development of vitrification around 2008 to 2010, they were able to show that the survival of frozen eggs almost equals or is equal to the survival of frozen embryos. So in 2013, oocyte vitrification should no longer be considered an experimental strategy, according to the American Society for Reproductive Medicine. Now let's talk about the most exciting strategy that has been brought forth the past decade or so, which is ovarian tissue cryopreservation, followed by transplantation. Here, we preserve part or the whole ovary to avoid gonadotoxic exposure or risk of early menopause. It was developed as an alternative method of fertility preservation when embryo or egg freezing is not an option. Essentially, we do it in 4 stages. First, we harvest the ovarian tissue by laparoscopy or mini-lap with Mobius. There are many techniques on how to harvest the ovarian cortex or to harvest strips of ovarian cortex. Once you get the specimen, you transport them in sterile NSS in 2 to 10 degrees centigrade. When they reach the fertility lab, they will undergo preparation of the samples for freezing. These are performed by our trained embryologists. These are very delicate steps, a crucial step in ensuring that there will be available follicles when they are transplanted back. The type of cryopreservation is either slow freezing or vitrification. So during the time that the patient undergoes anti-cancer therapy, their reproductive potential is stored in our laboratory. And when the patient already is declared in remission, years later, you can retransplant the frozen strips of ovarian tissue back into the patient, either orthotopically, meaning they're placed near the area of the ovary, or heterotopically, meaning at an area which is not usually close to the ovary, like your forearm or your abdominal wall. Once you do this, we expect that the graft of your ovarian tissue will grow, will take time and grow in about 3 to 4 months, by which time the patient will already be secreting estradiol. So whatever way you do, there is a possibility for pregnancy either by natural conception or by in vitro fertilization. So because of the consistency of data and the success with ovarian tissue cryopreservation, just last year in October 2019, the American Society for Reproductive Medicine declared that OTC, or ovarian tissue cryopreservation, is no longer considered experimental. And right now, it is an accepted strategy for fertility preservation. This is just to show you our first ovarian tissue cryopreservation case that we did in October 2015 at our IVF center in Carmi, in Safe Foods Global, where after harvesting by laparoscopy one of the ovaries, they were brought to the lab, and then we harvested the cortex, as much of the cortex from the whole ovary as much as possible, trimming them down to as thin as 1 millimeter, because the follicles are found in the outer 1 millimeter of the ovary. Now, it was crucial to explain that the patient's ovary could be harvested in any hospital, and then as soon as they retrieve the ovary, they can put it in a container of NSS under 2 to 10 degrees centigrade, and as long as the patient's specimen is brought to the IVF lab within 24 hours, that can be still processed as a specimen for ovarian tissue cryopreservation. Now, these are some of the cases that we did. We already have 11. These are just 10. But see that the various indications for ovarian tissue cryopreservation are mostly either breast or cervical. So I was just going to comment on the case that was presented by Dr. Tagle, that the case of cervical cancer that was presented could actually undergo ovarian tissue cryopreservation or oocyte cryopreservation, whichever the patient would be in favor of. Now, if the patient is already declared in remission and is allowed to can try to get pregnant, then we do ovarian tissue transplantation. We initially talked about the strips of ovarian cortical tissues. In transplantation, we can put them in subcortical pockets in the ovary, or we can suture them over the medulla of the ovary, or we can put them in the peritoneal window close to the ovary. So there are other techniques. There are even techniques where you mash the ovarian tissues into small bits and you put them into the pockets. And in many of these patients, they would get spontaneous pregnancies. The last type of strategy that we can do for the female, as already previously mentioned, is the use of GnRH agonist as a fertility protective drug. GnRH agonist is the only drug used as a fertility protectant because it suppresses gonadotropin levels, and seemingly, and because of this, it decreases uteroovarian perfusion by this method protecting the follicles. This is the theory that they said about GnRH agonists. However, the evidence on its benefit is a bit controversial. There are studies that say that it's really very beneficial, but there are others that contest it. For the moment, the update of the ASCO in 2018 is that GnRH agonists or analogs are not to be used to replace the accepted fertility preservation procedures, but they can be used as a co-administered treatment during the time of chemotherapy, hoping to protect the ovary from developing premature ovarian insufficiency in the future. In men, of course, it's much simpler. Semen cryopreservation collected by masturbation is the easiest, cheapest mode of fertility preservation for men. And they would recommend the number of samples depending on the quality of the sperm sample given. However, in certain men, there will be some difficulty in collecting after masturbation, so there will be other special collection procedures like electroejaculation and various surgical sperm retrieval techniques like PESA and MESA and TESA and TESE. And the latest is microtese, whereby you just cut open the testicle without cutting anything blindly. With the use of an operating microscope, you can take a look at which seminiferous tubules seem to be congested. If you find that area, you grab it because probably there are some sperm in those testicular tissues. When we talk about the strategies for prepubertal boys and girls, we only have one choice in each. For boys, we have the experimental testicular tissue cryopreservation, and in girls, ovarian tissue cryopreservation. In girls, no problem, because OTC is the only recommended procedure for fertility preservation for prepubertal girls. In fact, there are already a few pregnancies that have been reported after freezing ovarian tissues from pubertal girls, and when they grew up, they transplanted them back, they have already reported pregnancies. But in boys, it's not the same. It still represents a promise. 75% of childhood or adolescent boys will survive their cancer. But there is no other way to have hope except to have testicular tissue cryopreservation. But the problem is they have not yet developed the complete protocol to convert the immature testicular tissue into mature sperm. So right now, it is not yet applicable in the clinical setting. They've done procedures or experiments in animals, but that is not yet applicable in humans. There's still a long way to go for developing immature testicular tissue to be developed into a mature sperm. But they estimate that probably in 5 to 10 years, there might be application in the clinical setting. But what can you do if you have no choice for your boy, or your little boy without cancer? If you don't do testicular tissue, you completely shut the door. At least if you do testicular tissue cryopreservation, there might be hope in the future. This is just to show you our 6 IVF centers in the Philippines and their capacity to do embryo and egg cryopreservation, ovarian tissue cryopreservation, semen cryopreservation, surgical sperm retrieval, testicular tissue cryopreservation, and in vitro maturation. Different labs have different capacities, but we are able to provide a service of those different strategies in most. Actually, there are 7 IVF centers. A newly opened IVF center, a new one was opened in Angeles City recently. So we now have 7. So there are 5 in Luzon, 1 in the Visayas, and 1 in Mindanao. And this is important because when fertility preservation is made aware all over the Philippines, we will need more fertility preservation centers. And we'll be discussing that when we talk about networking. So what needs to be done? Fertility preservation is at the infancy stage in the Philippines. I'd like that to be my opening statement. And there are barriers to pursuing fertility preservation in the Philippines. Some of our previous speakers already talked about this. Healthcare professionals might avoid discussion of fertility preservation because they have the wrong information, or they have a sense of urgency to carry out cancer treatment, or they are completely unaware of fertility preservation. Patients themselves might avoid discussion because they are already overwhelmed by the cancer. So they're more worried and they forget that they might have a good chance to survive the cancer, and then will worry about fertility after. And there are also patients who think that delaying treatment might have negatively impact on their survival. And then there are also financial barriers and others. This is a report of the study that we did last year. This is the paper of our then fellow, Dr. Factor from PGH. And you may have been a respondent in that survey. And we would now like to report the results, knowledge, attitudes, and practices of Filipino clinical oncologists regarding fertility preservation in cancer patients. And we found that most clinicians, 58 to 85%, have no exposure with FP options. Most, 53 to 73, are aware about fertility preservation but have minimal knowledge, and 95% want added information. 65% have never consulted the CPGs on how to do fertility preservation, and 57% have never referred to a fertility specialist. So our conclusion is that there is an acute need to increase knowledge and awareness about fertility preservation methods and the international fertility preservation guidelines among Filipino health practitioners treating their cancer patients. Another issue is counseling, and and Dr. Francia and Dr. Tagles already talked about this a little bit. Infertility is a significant survival concern, and patients who receive information by counseling had lower levels of psychological distress and regret during treatment if they receive proper counseling. In this study by Let Her Know, they show that if the patient is counseled by a team of oncologists and the fertility specialist, their regret scale is much lower compared if they are counseled by the oncology team alone. And their satisfaction with life scale is significantly higher if counseled by a team of the oncologist with a fertility specialist compared to the oncologist alone. So joint counseling will work well for these patients. So late last year in September, we launched the Philippine Society for Fertility Preservation and had our pre-Congress course. This was in cooperation with the Philippine Society of Oncology. And we had our induction of our founding members, all 169 of them, and our officers. And with that, we became the fourth Asian country with a National Fertility Preservation Society. And I'd invite the various members of the different oncological societies that we are open for you to join us as members, or you can also be our partners. So the goals of the fertility preservation programs in the Philippines would include improving knowledge and skill, increase awareness by postgrads or roundtable discussions, create the referral system, link up with government and private NGOs, do research, and so forth and so on. We have started trying to increase awareness by starting with webinars like we're doing tonight. Next week, there will be more lectures about fertility preservation. We had intended to do a lot of pocket meetings and roundtable discussions, if not for the entry of the COVID pandemic. We have already made our frequently asked question flyers and brochures. They are just for printing, and once we print them, we will give all oncologists and reproductive medicine specialists copies for your own use in your clinics. We have started networking with private NGOs to spread the word even among lay people. This one we did with the I Can Serve NGO at the PICC. We've started doing additional research. We had a multi-country research on fertility preservation involving many countries in Asia. and found that we had similar problems all over. And then finally, we hope to establish a good referral network within the Philippines. And this model by the Japanese, who are about 8 years ahead of the Philippines in terms of fertility preservation, they set up a network of their regional cancer network, regional cancer hospitals, and their central oncofertility centers with regional ART hospitals. And they developed a very good protocol so that patients, as soon as they are diagnosed, would already be undergoing fertility preservation before they go through their gonadotoxic therapy. Last year also, we were lucky to have launched the PSFP at the time when the government was finalizing the National Integrated Cancer Control Program. And with this, with our entry, we were lucky to have joined their protocol of treatment for cancer control. We have insinuated ourselves so that when patients are diagnosed, young patients that is, are diagnosed, they could be given the option of doing fertility preservation before cancer treatment is started. And in their vision for this integrated control program of developing multiple regional cancer centers with a cancer center, Philippine Cancer Center of Excellence in Manila, following this model, we believe that we should be setting up collateral areas of fertility preservation to be able to serve our patients requiring fertility preservation. So this is what we propose. Instead of our patients being brought straight to undergo cancer therapy, we hope they could be referred to the team for fertility preservation. They will be seen by our team of nurses, the fertility doctor, and a counselor, and undergo the strategy for fertility preservation. And once we're done, without extending the time for required cancer chemo radiotherapy, they're brought back to your care. So we are here very, very excited to have multidisciplinary alliance with the various societies, especially the oncologists, the reproductive medicine specialists, the primary physicians, the OBGYNs, the pediatricians, the surgeons, the family physicians, and the paramedical people. We hope that with multidisciplinary cooperation, we will advance the field of fertility preservation. Just one word, because we're in COVID, just one word about doing fertility preservation procedures during the COVID-19 pandemic. And the big international societies advocate that the cessation of fertility preservation of fertility services does not apply to medically necessary fertility preservation needed for cancer patients. They are time sensitive, so they require urgent treatment. And these are seconded by the other big societies like your ESRE, your Alliance for Fertility Preservation, and even our local society, the Philippine Society for Reproductive Medicine. So, in summary, there is a worldwide trend for the promotion of fertility preservation. The field of fertility preservation is evolving, trying to keep up with other medical disciplines such as cancer therapy. There is a need for fertility preservation in the Philippines with about 15,000 cases per year. The local FP programs are in its infancy stage, and all local fertility centers are able to provide most fertility methods as required. And much needs to be done for the promotion of local fertility preservation, and multidisciplinary partnerships is a step in the right direction.
Now let's go to our question and answer portion. So let's welcome our speakers in their webcams. No? Can you share your webcam? So for our first question from Dr. Ellie May Villegas, what's the gonadotoxic potential of doxorubicin being the most commonly used chemo among female? I think this is Dr. Francia.
Thank you very much, Dr. Villegas, for the question. So we know that doxorubicin is an anthracycline, and it actually can cause apoptosis in the oocytes. But most of the studies were done because we use it in combination with cyclophosphamide. So the range is about 20 to 70%, so intermediate, but it's really, it's hard to, the studies that were done were mostly in combination with cyclophosphamide because we rarely use doxorubicin as a single agent, especially for breast cancer. But to answer your question, it's intermediate risk.
Okay, thank you, Dr. Francia. So to Dr. Tagle, why not do ovarian transposition procedure to avoid the radiation field prior to EBRT? From Dr. Richard Cacho.
Yeah, so for the first case, so ovarian transposition was not offered because at that time they were thinking that the left ovary was also involved. So they requested for a PET scan and there was a questionable lesion in the ovary. So they decided not to pursue that option. Yes.
Yes, thank you, Dr. Tagle. I think another to Dr. Tagle, what dose constraint of the ovary would you advise to use in giving ovarian sparing radiation therapy? Is it the effective sterilizing dose that depends on the age? From Dr. Stephen Shokon.
Yes. So as mentioned, no, so for the women, there's a marked age dependency in radiosensitivity. So it will depend on the age of the patient. So for prepubertal age, so maybe we can, as mentioned in the literature, it should be less than 12 gray. And then for the premenopausal, then it should be less than 2 gray. So there's a marked age difference because primordial follicles are more resistant to radiation. Yeah.
Yes, to Dr. Novero and to Dr. Francia. How long can we delay cancer treatment initiation after a referral to fertility specialist is done? I think this was also mentioned in the lecture.
Dr.
So
Francis,
how long
to
can we
answer
delay
that,
cancer?
we will fit into the requirements of the oncologist.
Yeah, so ideally we know as oncologists, we must start treatment within 4 to 6 weeks after surgery. So, and I think that's the window that's enough time for the fertility specialist can actually work with us within the time period as he was shown in his presentation.
Yes po. To Dr. Novero, regarding OTC, what is the percentage of success for natural pregnancy versus IVF? From Dr. MV Ocampo.
There were some studies that were done if the transplantation would be done orthotopically, the chance for pregnancy is somewhere between 30 to 35%. In fact, there are more pregnancies with orthotopic transplantation than IVF by a big ratio. So if by far you can do orthotopic transplantation, putting back the ovarian tissues, it should be close to the ovary so they have a chance for natural conception rather than by IVF.
Yes, thank you, Dr. Novero. Another question from Dr. Maria Shasu to Dr. Novero. Can you cryopreserved tissues be implanted on another?
That you mean the tissues were collected from one woman and it will be transplanted to another woman?
I think that's the question, sir. Yes.
That will be quite difficult to do. Normally, we like to put the same tissues to the same person. You will be doing an allotransplantation if you'll be doing that. Nobody really does that. It's usually an autotransplantation.
Yes, from the same inquirer, Dr. Shasu, can cost of the procedures be made affordable for most patients? I think this is Dr. Novero.
Yeah, if the question is with regards to embryo and egg cryopreservation, yes, there are some protocols that can be done so that the cost of ovarian stimulation and egg retrieval and storage can be brought down really low. Same also for ovarian tissue cryopreservation, because right now just the procedure of processing the ovarian tissue and then freezing them is already substantial. Yes, we are working on that because we're in the early stages of fertility preservation. Costs are a bit high right now, but eventually we think we can bring down the costs.
Again, to Dr. Novero from Dr. Jocelyn Santiago, an OB-GYN from Laguna. So regarding oocyte freezing in general, even without cancer, what do you do to those oocytes that were not used? Do you discard them or just keep them in frozen. So when the couple decided not to use the remaining oocytes because they have one successful pregnancy, and how much does it cost for its storage, and how long can they be stored?
Yes, there is no need to keep freezing, keep eggs. These are eggs. These are unfertilized eggs, cryopreserved if you're not going to use them. And there's no ethical issue regarding the storage and the the discarding of gametes. As long as they're not embryos, there is no controversy. The cost for freezing of oocytes or embryos even is in our center is approximately 12,000 per year.
Yes, so thank you, Dr. Navarro. So there's a comment and a question from Dr. Mod Faisal Ahmad. In cervical cancer, why the first case discussed was offered fertility preservation as already beyond 1B2, she's stage 3. So during the discussion, although she was referred to for fertility preservation, I would suggest adoption if she survives as despite with oocytes cryopreservation, she will have no chance to use it. Or despite stages, is the patient able to choose what she wants for fertility preservation? I think this is for Dr. Francia and
Yes.
Dr. Navarro.
So thank you for your question. So the patient has locally advanced cervical cancer. So I think one option which may or may not be available to your country is if it's correct to Dr. Navarro, you can still harvest the oocytes, and some countries actually do surrogacy. So meaning another woman will actually carry the child eventually if that's something that's available to your country. So I guess it depends on the availability. But I think that's something I see as an option. I still harvest, but still using her own eggs.
Yes, that is. I completely confirm that that is an option for the first case presented. Meaning, because it will be impossible to do ovarian tissue cryopreservation and then the tissue will be transplanted in another patient, then the best way to go would be to do, because it will delay treatment only for about 2 weeks, then the best way to do will be to do ovarian stimulation, collect eggs, and form either embryos with the donor. But of course, those will not be done in the Philippines because we don't do third party in the Philippines. But if it's acceptable to the mores of the couple, they can do third party IVF in another country.
Thank you, Dr. Navarro. Last two questions from Dr. Romerico Torres. What is the dose of letrozole and how long should you give it? I think Dr. Navarro mentioned it.
The usual dose, the usual dose that we give is about 5 milligrams per day, and you start 1 day before the start of stimulation, and you give it until 1 week after the end of stimulation. I'll show you the protocol, Dr. Torres.
Thank you, Dr. Navarro. Dr. Jasmine Igama, I think this is from Baguio. We see the importance of fertility preservation. How much would it cost, and is there a move for HMO and PhilHealth coverage? Dr. Navarro, I think.
Yeah, you guys have to help me here. We've been trying to talk to HMOs and to even the government because we were included in the National Integrated Cancer Control Program, including fertility preservation. So there will be a certain budget that will be allotted for fertility preservation for Filipinos, but I don't know how much that budget would be. On the private side, yes, as an addendum to the previous question, the cost normally for one round of in vitro fertilization, or at least until egg cryopreservation, would probably be somewhere between 200 to 300,000, depending on the age of the woman. However, for ovarian tissue cryopreservation, of course, there's a separate cost for the harvesting that will be by the individual gynecologist for that, and then the processing will be For the moment, the cost processing of freezing ovarian tissues is about 80,000.
Okay. To Dr. Novero from Dr. Teresa Malen, can you please give us an estimate on how much ovarian tissue cryopreservation would cost? Would it be more or less the same for pre and post-pubertal girls? The reason I am asking is because I think this really would be a one huge barrier, especially since some would prioritize immediate treatment and would not spend more for fertility preservation.
Yes, I agree with your views. Number one, the cost of the harvesting of the ovarian tissue will be dependent on the center where it will be done. We don't have to do it ourselves in the fertility centers. The various gynecologists on their respective centers can do it remotely. So the cost is with them. So I guess the cost for harvesting will be variable. However, the cost of ovarian tissue cryopreservation, meaning processing the ovarian tissue until freezing, is about 80,000 pesos right now.